Good late morning. Welcome to the CLARiTI luncheon. We're excited to talk to you today and give you the latest updates, and also have a space to answer your questions and address any concerns or feedback or suggestions you have about the CLARiTI program. We're very close to getting started with this project after a really long buildup. This has been such an amazing team effort with a lot of people. I don't have time to name all of them. There's 47 investigators on this project, and there's 36 sites, 37 sites. So lots of moving parts here, lots of people involved, and just want to thank you. So that keeps going back, doesn't it? This is a, hopefully that stays there. This is a QR code. You can get some of the materials for today's meeting, the slides, and other materials at that QR code. This is a quick introduction of the agenda that we'll be talking about today. We're really devoting most of the time today towards inclusion. We want to get started off on the right foot, making sure we're thinking about inclusion right from the get-go. That's a big part of what we think will be the success of this project, is how diverse our cohort is. We will also be focusing on disclosure, and you'll hear our plans for disclosure today, and they'll also be repeated, we think, in the clinical core. Tomorrow we'll be talking more about disclosure. So let me first just, I think I've covered this in the last session, so I won't spend any time with this, other than to thank all of the investigators who are here or not here, listed on this slide. There's, as I said, a number of moving parts with this, and a number of people that have made all of this possible, especially NAC. And NAC is really stepping up to make this project what it is so far. Okay. All right. So, okay, let me talk about some of the survey results. Thanks for your patience with all the surveys that you've taken. There's been 3 CLARiTI surveys in the first quarter of the year. On the first survey you took about enrollment capacity and PET ligands, you said you could enroll 3,200 participants. And since we only need 2,000, that suggests that there's still quite a bit of headroom and capacity at the sites to fulfill your P30 obligation and any other things you want to do. We also asked you in that survey about how you wanted us to support your P30 obligation. And a number of you have said that you would like to explore that further and see if there's a way of perhaps combining protocols, so you don't have a separate P30 protocol from the CLARiTI protocol. Is there a way to combine those such that we can keep the money separate and the credit separate for your P30 and CLARiTI, but still not have the overhead of having 2 separate protocols? We're working on that, and we think we have a tentative solution to that we can talk about. And as I mentioned in the last session, there's I think, going to be an upcoming need to think about the distribution, the balance really of the radio tracers, and whether we want to get dependent on the Lilly tracers when they're making fewer concessions for research. They've given us a number of free doses. Those will be expended right within the first year, we think, and then we'll be paying full price. That balances out to what we thought we would be paying anyway, which is around $2,500 for a dose. But if that may create a dependency for you as you go forward without beyond CLARiTI and into the next set of things you plan to do. Do you want to be entrenched with radio tracers that you'll now have to pay full price for? So those are things to think about. We're not saying that you shouldn't do that. It's just something we want to think through that with you and make sure we're not creating an over-reliance on one company. Okay, also wanted to mention the blood collection protocol here. We mentioned this in the last meeting as well, but the important part here is how rapidly these new blood markers are developing for TDP-43, for alpha-synuclein. There's proof of concept tests that have already been presented at ADPD. There were several presented. So we think that the vision of having an etiologic profile from imaging and blood is likely going to be possible with this project. And this is in partnership with NECRAD and with many others who are really helping make all this happen. But it does require that all of us do the same blood collection protocol as consistently as we can. And as we heard in the last session in the morning, there is, even though we're supposed to be following the ADCFB protocol, there's still a little bit of heterogeneity between our sites. So wanted to, we talked about this before, where the next phase of this project is really getting you the money. And that's what we want to do. And that'll be our goal over the next few months, is to get these subawards established with each of you so that we can all get going and get momentum with this project. And those subawards will be initiated from NAC. Okay, well, let me, the main thing I wanted to do was just welcome you to this session and thank you for being here. And now I'll turn the time over to Dr. Monica Rivera-Mint, Dr. Ozioma Okonkwo, and Dr. Dorothy Edwards, who will be leading our first session in this breakout meeting about the CLARiTI Inclusion Core. Dr. Rivera-Mint is professor of psychology at Fordham University with a joint appointment in neurology at the Akan School of Medicine at Mount Sinai. Dr. Okonkwo is professor in the Department of Medicine at University of Wisconsin. And Dr. Edwards is the leader of the Wisconsin ADRC ORCOR and is the current chair of the National ORCOR Steering Committee. So let us all welcome our first session.
Thank you, Sterling.
Thank you, Sterling. Hi, everybody.
Can you all hear us okay? No. Can everyone hear us?
We can hear you.
Okay, great.
Thank you.
All right. Welcome, everyone. And it's our pleasure to present an overview of the inclusion core for CLARiTI. And next slide, please. All right, so here are the agenda items we're going to be looking to cover with you all this morning. Next slide. So some of these are things that you may have heard if you were at some of the, at the webinar we had in March, I believe. Basically, the mission of the Inclusion Core is to ensure that persons who are underrepresented in AD and research, are being included in a substantive way in CLARiTI. And that our goal here is to deploy a community-engaged, culturally informed research approach in close collaboration with all of the CLARiTI cores, particularly the admin core and the disclosure core, but more importantly, to work with the local OR core at each of the ADRCs, because we know that without you all, the goal of CLARiTI is not going to be as successful as it could be. So the first major goal for the inclusion core then is to ensure the inclusion and engagement of persons who are underrepresented in research, and the target here is 25% for CLARiTI. And then the second major goal is, as mentioned, to establish very close working collaborations with all of the local OR cores in order to meet the inclusion goals for CLARiTI. Next slide. So here is the team that currently works on the inclusion core for CLARiTI. As you already heard, The core is co-led by Monica and myself, and we have our co-Is and Dr. Desiree Bird, Vanessa Guzman, and Charles Winden. And then we have our support staff who help us to round out the team and really are our boots on the ground for CLARiTI. Next slide, please. This is just another kind of schema of kind of the inclusion core structure for CLARiTI. We have the core leads there, and then we have the pillars on which our work is going to be based. A major part of this at the top right is the Community Science Partnership Board. This board is going to be very critical to the inclusion and engagement goals for CLARiTI. Again, I believe that these slides are going to be available to you guys after now. So in the interest of time, we're not going to go through in depth each one of these slides because I think our time is a little bit spent. Next slide, please. So again, to dive a little bit deeper into the milestones for the inclusion core, as you already heard, the target here is that 25% of all the participants who are enrolled into CLARiTI are going to be individuals from underrepresented populations. And the way we've operationalized that for CLARiTI is, first of all, individuals who are from ethno-culturally minoritized groups. Then secondly, individuals who have low SES. And for the purposes of CLARiTI, we are using education as a proxy for SES, so individuals with 12 or fewer years of schooling. And then lastly, individuals who dwell in rural areas. To help you meet these goals, the Inclusion Core has a cadre of resources and staff that we are going to be putting at your disposal. The first one is that part of your funding is funds to recruit a community research liaison who is going to be locally based at your ADRC, hopefully within your or core. This person is going to be your boots on the ground for inclusion activities. And then we're also going to have community research navigators. These individuals are centralized and based within the inclusion core itself. In addition, you're also going to receive funding up to 10K every year for you to use to support inclusion engagement activities at your ADRC. And then the Inclusion Core is going to be working with a marketing company to provide you with tailored inclusion engagement materials. And as mentioned previously, the Inclusion Core is forming a community science partnership board that is going to help guide the work that we're going to be doing. Next slide, please. This slide kind of just goes into a little bit more detail in terms of the CRL and the CRLN, just kind of to give you a little bit more flesh to the bones of what this, how these two roles are different and how we envision them being used to support your work for CLARiTI. But again, the biggest difference is that the community research liaison is going to be housed within your ADRCs, whereas the community research navigators is going to be housed in the inclusion core. But regardless of whether they are housed in your ADRC or within the inclusion core itself, these two groups of staff are really positioned to enable you be successful with the inclusion core mandate for CLARiTI. Next slide, please. All right, so again, our second milestone then is to partner with each of you very closely to support the success of your protocol. And for this, we are going to be looking to each of the, because we realize that all the ADRCs are different. CLARiTI is not like your typical multi-site study where all of the sites are harmonized and do things exactly the same way as determined by a central coordinating center. You all are ADRCs and you have your own independent funding and cultures and ways of doing things. So the Inclusion Core is going to be looking to have a personalized and tailored approach with each one of you. So we're going to be looking to you for some guidance as to how we can best partner with each of you to meet your inclusion goals. And part of that is that we plan to begin to set up some one-on-one calls with each of your centers to get a little bit more details as to how you foresee this partnership working. Next slide, please. So just to go into a little bit more detail in terms of the partnerships with the all cores at your ADRCs. As mentioned already, we plan to have onboarding calls, and not only an initial call, but also to have a regular check-ins between the inclusion core and the ADRC all cores. And we plan to consult with each of you, and we invite you to consult with us as you get going with rolling out CLARiTI at your ADRCs. We plan to have a series of webinars, and hopefully some of these webinars can also be done in person at the fall or spring ADC meetings for all of the members of the all core and their team members, so that we all can be on the same page with what it really takes to do community engaged research and do it well. We are putting together for you an archive and repository of resources and various training materials. Again, this might be some things that your centers and your all cores already know and do very well. Some of them could be new, but regardless, we are putting this together to make them available to all of you. Plans are currently underway for the inclusion core leadership to participate in some of the meetings of the all core steering committee, so that there is that very close connection between CLARiTI and via the inclusion core and your all core via your steering committee. And again, in the future, we hope that it will work for us to be present at the ADRC's fall and spring meetings, so we can all meet and talk in person. And then, as you know, you all filled out a site survey for the inclusion core. Thank you so very much. And that survey was to enable us understand your local preferences and practices, so we can best partner with you. And on that note, I'll hand it over to my co-lead, Dr. Rivera Mains.
Thank you, Dr. Okonkwo. And again, hello, everybody. It's a pleasure to be here, at least virtually, with you all. Thank you. Next slide. Yeah, so we're going to talk briefly about our inclusion core site survey. Next slide, please. And before I get started to describe this slide, and we're just going to provide a couple of high-level overview snippets from that slide. But Ozioma and I just want to thank Ann Buffington, our project manager, for doing such a nice job with this survey and really collating all of these data so beautifully. So you're just going to get a couple of highlights now, but everybody should have access to a more comprehensive summary of those findings that she put together for us. So first of all, in terms of some background, again, as Ozioma said, we distributed this slide or this survey in March to site PIs and the core leadership. And we were really pleased to get 32 sites to respond. So thank you very much to all 32 of you. And one of the questions that we asked was, will you recruit anyone to CLARiTI who is not currently enrolled in your center's clinical core? And we wanted to know this information to start trying to figure out how we can support the sites if we're really going to be focused more on retention and study engagement efforts, or maybe more inclusion and recruitment efforts. And as you see here, it was pretty split, 1/3, 1/3. So about one third of the sites said no, they will not be doing new recruitment to replenish their clinical core. Little over a third said yes, they will be recruiting for that purpose, I assume. And then 1/3 wasn't sure. So there's certainly more to to disentangle and figure out. But what's really important for us then is to be thinking about both issues then. So we will be thinking about supporting your sites, and specifically you'll let us know what each of your sites' goals are, but we'll be preparing materials for both purposes because they're a little bit different. And as you see there to the side, there's just a little note just reminding folks that CLARiTI participants must be enrolled in your site's clinical core and have a NAC ID. And there's just some more bits of information there that I'm not going to read verbatim. And again, you're going to have a copy of these slides. Next slide, please. We also got some rather rich qualitative information. So thanks again for folks who took the time to fill this out. We wanted to know about barriers to URP inclusion and facilitators. Again, URP standing for underrepresented populations, as Ozioma already described. In terms of barriers that came up at the different sites, I will read these and share these verbatim, at least a couple. So one had to do about participant reluctance to complete the study procedures. Scheduling challenges came up quite a bit, and really needing to be able to possibly be scheduled outside of normal business hours. Participant burden was another one, especially with regard to transportation. And this quote on the bottom we found really salient. The most significant barrier will be convincing older adults and their adult children that blood draws, MRI, and PETs are safe and necessary. And that's really informative for how we're going to be thinking about tailoring the materials that we'll be providing for you to review and for us to deploy. In terms of facilitators for inclusion, again, significant site expertise. We have such an incredible cadre of ORCORs and the ORCOR steering committee, and so much site expertise for running community events and educational outreach. So that's a real strength for this program as well. Also successful partnerships that have already been established at local, regional, and national organizations. And then certainly ensuring that study staff reflect the populations who we wish to connect and understand, right? So that's really wonderful that folks have been paying attention to that. And then this quote we also found quite salient. So somebody from one site said, we have found that a constant presence in the community to provide education, outreach, and support has aided in retention of all participants, but especially our underrepresented populations or group participants. And that's what it's about. And, we're working from a culturally informed, community engaged research approach, which so many of these ORCORs have already demonstrated such expertise in. And as as those of us really deeply immersed in this work know, we really need to be in it to win it. It's that sustained connection and engagement that will win the day for us in CLARiTI as well as for the clinical course. Next slide, please. And so here's some additional results. So let's focus on the results on the left. Which community engaged research training topics would be most relevant to your site? And we do want to provide, as part of our inclusion core resources and services for all the participating sites, we do plan on providing trainings and resources for you. And if you jump all the way down to the bottom couple of responses, those were the responses that got the most endorsement. So the first one was for community, so for training around community and outreach strategies. The second was working with specific populations, which I really appreciated. And here, we would conceive this as not just let's say ethnoculturally minoritized populations, but as you see, we're really trying to be more inclusive across multiple dimensions of diversity. So here, perhaps, we could focus on rural populations, and I want to thank Brian for the comments about endorsing our inclusion of rural populations as underrepresented, and also people from low resource settings. So those could be different populations we could focus on, and also getting training on how to conduct, I think, community advisory boards or participant advisory boards, and we can talk more about that as we move forward. And on the other graphic, the question was, what kind of marketing materials would be useful for your site? Again, we really want to do a good job of being a resource to you and making every single one of your sites, thrive and be incredibly successful. And so some of the things that the top two here that really popped out for us were, materials to recruit, again, specific groups. So what we're hearing is really wanting to get that tailored training and materials and resources to be successful. And second, getting materials to recruit for CLARiTI from the clinical core. So again, kind of that retention and study engagement point to kind of transfer them into CLARiTI. So we will be thinking very deeply about that and look forward to getting your input. Next slide, please. And lastly, we wanted to know about really whether or not we need to be thinking about developing materials for Spanish speakers. And based on what you all reported, the resounding answer is yes. So the question was, does your center have capacity to enroll Spanish-speaking participants? And a whopping 50% said yes. So 16 out of 32 sites, which is really exciting. Not only that, but 12 sites have bilingual neuropsychologists on staff, which I think is just extraordinary. And 15 sites have bilingual psychometrists. So this is also some very useful information for us. So thank you for sharing that. And we'll be incorporating that into our punch list of things that we want to start developing for you all. Next slide, please. And with that, lastly, we want to share some frequently asked questions and resources for you before we move on to question and answer. Next slide, please. So frequently asked questions and resources. First, how will inclusion be monitored during the study? So there's going to be a study dashboard, which is currently being developed by NAC, and we have spoken directly with NAC folks and NIH folks about it, which will allow the ADRCs to view site and study-wide performance on inclusion metrics. So this is still under development, but we will make sure to keep you posted as this evolves to have those really important resources available to you so you know how you're doing. Another question that came up, number 2, how can I learn more about CLARiTI inclusion plans? Well, we already have one webinar that we have in the books already. So you can check that out. It's was presented on March 27th. So there's lots of information there as well. And lastly, I have questions, concerns, or ideas about engagement of participants from underrepresented populations. How can I share this, or who can I share it with? And we already have our very own email, so you can contact us at CLARiTI inclusion@medicine.wisc.edu, and we will be happy to connect with you and glean all the wisdom that you can share with us. We're very excited to be working with all of you and just learn and learn together and really be successful together. Next slide, please. So with that, Ozioma and I want to say thank you on behalf of our whole team, and Alex, our co-investigators, everybody. Thank you so much. Muchísimas gracias. We're so happy to be here with you. And if you want to just take a picture with the email so you can get it if you think you want to email us, again, you will have access to these slides as well. And I think with that, we could probably release the slides so that folks might be able to see us a little better, and we can have a bit of conversation. I believe we have some time still. So, right?
Yes, we have about 10 minutes.
10 minutes?
Yeah,
Okay.
that's great.
Great. So it's time for Q&A. So let's go ahead and chat. Is Dr. Farrar Edwards here, by the way?
Yeah, I think I just saw her walk across the
Oh, okay. How
the
funny. I
room.
was wondering. Okay, great.
I'm
So
here,
for this-
Monica.
Oh, hi, Dorothy. You're Dr. Farrar Edwards. So I don't know if you would like to get the ball rolling in terms of questions or comments, criticisms, anything.
Yeah, I'm ready. So thank you, Monica. Thank you, Ozioma. As you can see, Dr. Okonkwo is sitting on the terrace at the University of Wisconsin, probably sipping Spotted Cow, our very special local beer that doesn't leave the state. So I'm sorry he couldn't be here. So on behalf of the ORCOR Steering Committee and my colleagues who are here in the room with me, Darby Moorhart from Northwestern and Monica Parker from the Gozzietta Emory ADRC, and Sophia Wang, who is here virtually, we want to enthusiastically support CLARiTI and the Inclusion Core. One of the great things about our network is the collegiality I mean, we are unique among multi-site disease-specific programs to work so well with each other. And so that's one reason that CLARiTI is going to be successful, is we have a long history of collaboration. But secondly, as an ORCOR leader, I want to thank the CLARiTI team for actually putting the financial resources into the budget to make this work possible. And I can speak for ORCOR leaders that it's really, really important, and we appreciate the time and effort that's gone into organizing the Inclusion Corps and the resources. That said, we know that every center is different, and that the point of contact with participants may vary from site to site. And the freedom and flexibility to design the recruitment program and retention program, because we recruit to retain for this program. We want the individuals enrolled in CLARiTI in the first year to stay in so that we can continue to benefit from their participation. So it's very participant focused, which I think is really important. The last thing I'm going to say is that the ORCOR Steering Committee is working hand in hand with the Inclusion Corps, and there will be a lot more interaction in the future, specific trainings. We're here to help operationalize the program. And so just so that you as center directors and clinical core leaders and other Inclusion Corps leaders know that there are many, many resources that will be developed in the future. So I'm going to stop talking and start fielding questions.
So this is fantastic, and thank you very much for the free lunch. Always appreciated. So this is just a really wonderful initiative, and it is going to take a team. And certainly at our center, we realize that. So the CLARiTI initiative is actually embedded in the clinical core with strong links and facilitation by the imaging and biomarker core and support by the ORCOR. But up to this point, you know, there have been surveys that are just going out to ORCOR people that know very little about how we're setting up CLARiTI within our own center. So actually our CLARiTI community recruitment person is not going to actually exist within the ORCOR or the clinical core. They're going to exist within CLARiTI at our site. So I think it's just very, very important that we really, even at this early stage, make sure that we are personalizing those contacts and reaching the folks that ultimately are going to be coordinating the integration of all the cores together. And I understand, Dorothy, being an ORCOR leader and the like, you know, and the way your center's set up, you may well be running charge on CLARiTI, but it's not that way in every center. And to avoid confusion within centers, I do think it's important that we have our contact lists really laid out well for the individual centers that are going to function in a diverse fashion to reach our diversity goals.
Right. I think what you said is really, really important. So not only does there need to be communication across the CLARiTI sites with the Inclusion Corps, but there has to actually be better communication inside of centers. So what you'll find is usually the ORCOR staff are the people with the community who actually have the relationships with community partners. And as you saw on the slide that Ozioma showed, these community partnerships are absolutely essential for assuring participants that their needs and concerns are going to be met. So internal to your center, you're going to have to work really hard to make sure that you're learning from the ORCOR leader, your ORCOR staff, not the leaders. Usually it's the staff that are out in the community, because they're the individuals who actually know the participants really well, and also are able to voice their concerns and bring them forward to these navigators so that problems can be solved before they get out of hand. Because, you know, problems tend to multiply when you don't pay attention to the little things, not so little things like transportation or the time of when appointments are scheduled. And I know that the Inclusion Corps staff are very, very sensitive to these issues. They're coming through in the survey. And we know this because many are engaged in scheduling individuals for imaging already. But thank you for your comment.
And Dorothy, if I may, if it's possible for people who come to the mic to introduce themselves and their center, just to orient us to whom they are and where they're coming from, that would be helpful, please.
Okay, thank you, Ozioma.
Thanks, Dorothy. And we want to thank you for that comment as well. That's really important. And we want to be very mindful of inter-core communication and collaboration. Absolutely.
Yes.
Hi, this is Annika from the University of Washington ADRC. I'm the administrator. It's also more a comment. I'm absolutely blown away by half of the people you surveyed have Spanish-speaking visits. It's just phenomenal. I had no idea, and it's so wonderful to see. It's more of a comment that the decision to do that, how many years ago? Many years ago, to roll out the Spanish-speaking UDS. Took many years for this to become a clinical Spanish-speaking clinical visit, which will now impact the ability for CLARiTI to do the recruitment at once. What's the, this is a long game. What about other languages? So we need, if we talk about 10 years from now, we're going to have, if we started a new language now, and NIH and NAC people are in the room, that's why I'm saying this. If we put in the resources now, we may be able to get somewhere in 7 or 10 years' time. But we can do this CLARiTI recruitment because of those resources put in before CLARiTI ever existed. So I just want to say, we really want to do inclusion. Let's think about how to fund more languages for the UDS4 and make it a reality, because that 50% Spanish-speaking visit for 50% of the course is just amazing.
That's an excellent point. I want to remind people that last year in the fall meeting, we had a session on multilingual assessment led by Miguel Arce from Colombia. That's available. The video is available, but we spent a whole session just being able to speak Spanish is different than actually doing accurate and effective multilingual assessment. So we have some expertise in the ORCOR for that as well. And I would encourage those centers that perhaps may have some questions about assessment of multilingual participants to sort of connect with Miguel and also to look at the video from last fall's meeting.
We do have a virtual question that I wanted to interrupt with, if that's okay.
Yes, please.
Yeah, so it's actually from Dr. Sophia Wong from Indiana. Sophia, are you able to unmute and ask it, or would you like me to?
No, yeah. Can everyone hear me clearly?
Yes.
Okay. Well, first of all, I want to thank everyone for getting together. It's just an amazing conversation that we're having. I think one thing that when I first met with Ozioma and Monica, they said, "What's the key to success?" And I said, "This CLARiTI is really going to be a measure of intercore collaboration." I think the biggest challenge I think that people are going to be facing is getting people to do neuroimaging, MRI, PET scans. And I think I've been very fortunate that I've been a physician to be able to go out in the community, but people have a lot of questions. They're really worried about the safety. They're worried about the necessity. I think everyone's heart's in the right place, but I think there's questions. And I think we also need to look at models like Rush. I think their clinical core physicians will go out with their ORCOR. So I'm hearing a lot of conversation about what ORCOR knows versus what clinical core knows. I think if we can figure out how to unify that knowledge, and every center will find their own way and their own pathway. But that's essential, because that's what our future participants are looking for. They want to know that people are going to see them for the visits. They want to know who's going to be looking at my imaging data. What are you going to do with it? There's security concerns, right? These are savvy people. Even if their education level is lower on paper, they're savvy. And I think it's very important that we all come together and within each center to come out to the communities and hear the same voices and the same messages. So that way their participant experience is also consistent with what they're being told in the community. So thank you again, and great ideas that are coming out.
Thank you,
Excellent
Sophia.
points.
We do have to wrap up questions. If there
Oh.
is any last words from Dorothy, Ozioma, and Monica, we can ask any questions in the lobby for in-person folks that still have them.
Thank you.
Yeah, I just wanted to say thanks to all of you again, and we look forward, Monica and I are very excited to engage in this partnership with all of the ADRCs and the ORCOR leaders, and we think it's going to be highly successful. Thank you.
Absolutely. Thank you so much, everybody. Take care and be well. Look forward to working with you. Thank you.
All right, we're gonna switch gears a little bit to disclosure and visual reads. So we're first gonna hear from our disclosure core leads, Annalise Rahman, who's an assistant professor at Michigan, and Lindsay Clark, who's an assistant professor at Wisconsin. We'll present to us, and then we'll have a very brief presentation from Gil Rabinovich, a professor at UCSF, ADRC on the visual reads that his core is planning. So thank you, Annalise.
Hi, everyone. Hopefully we're not in a post-lunch stupor. Very excited to be here from the Michigan ADRC to really get the opportunity to kick us off by talking a bit more about the survey that we sent out to all of you. This is just a quick introduction to the disclosure core team. One person that I want to highlight in particular is Haley Cole, our newest study coordinator. She's lurking in the back over there. She'll be also at the CLARiTI booth. So since we'll have some limited time for questions, I just want to point her out because she'll be happy to note down your questions and possibly answer some of them too. I'm going to skip over this in the interest of time, also because Lindsay is going to be covering this in greater detail, but my role is really to talk about the survey results that we had gathered over the course of the past few months. The goal with this survey was really sort of fourfold. First, we wanted to gauge current interest and engagement in disclosure practices across the ADRC network. We also wanted to understand the current infrastructure and resources for disclosure that exist, as well as the barriers. Because we know that so many sites are already, amassing expertise in disclosure, have really well-established disclosure protocols, another goal was just to collate the current disclosure practices and resources. And finally, we are interested in partnering with centers, some of whom may have already started the disclosure process and some who are completely new to disclosure. So we were hoping to use the survey to also identify potential pilot sites. In terms of the methods, we started with a survey that was sent out between September and November of 2019 by Scott Roberts and colleagues from the Agreed Dementia Group. This was a survey on disclosure practices across the center network, and it was filled out by about 30 sites. So we started there. We replicated many of those questions, but also had additional open-ended questions to gather a bit more detail. The surveys were sent out earlier this spring. And again, I just want to say thank you to all of the sites who participated. We had 100% response rate, which is incredible. We know there were multiple NAC surveys and CLARiTI surveys going out at the same time. So very excited to share more. And I'm really going to jump straight to the punchline to share some of the details here. So I know this is a busy table. This is, again, kind of replicated from that survey by Scott Roberts and colleagues in 2019. And what we have here is split by the type of biomarker information or personal data that's disclosed, as well as the potential audience. In that Roberts survey, they split the audience or participants by whether or not they had cognitive impairment, defined by mild cognitive impairment or a diagnosis of dementia, or individuals who are cognitively asymptomatic, so normal with or without cognitive complaints. And just to walk through these data, we see that the centers are fairly stable in terms of the disclosure of neuropsychological test results and research diagnosis. This is something that the centers have adopted in a fairly widespread way, which is great because we know that NAC cares deeply about this, as does the NIA. We are also seeing an increase in the release of structural MRI results for both cognitively symptomatic and asymptomatic folks compared to 2019. When we look at genetic test results, a few sites are actually disclosing this type of information, though there was an increase specifically in the disclosure of ApoE. In terms of CSF biomarker results, again, relatively rare across the ADRCs, and still we are seeing more disclosure of this type of information now versus in 2019. Now, a big focus for CLARiTI, because where we're going to start is pet disclosure, was the return of individual pet results. So back in 2019, 43% of sites were already disclosing amyloid results back to individual participants with cognitive impairment. We've seen that that's fairly stable. However, there's an increase of disclosure of this type of information to individuals who are cognitively asymptomatic. Additionally, we're seeing an increase in the disclosure of tau data. While it's still a small number of sites, we learned quite a few from those sites who are already disclosing those data, and that's something we'll be focusing on more in this presentation. So to jump in there a little more, in terms of amyloid PET results, we saw that 53% or 19 of the current sites are already returning amyloid PET results to individual participants, and 42% are interested in the future. Interestingly, we saw that sites were also disclosing amyloid PET results relatively regularly. In contrast, when we look at tau disclosure, we see that 5 sites technically endorsed engaging in some level of tau disclosure. There's an asterisk there because there was one site who, on follow-up questions, indicated that they do actually disclose tau, so that number might be 6. And many of you are interested in moving towards tau disclosure in the future. Of note, though, the decision to disclose tau certainly seems like a more complicated one. So no sites currently disclose tau routinely. It's to specific populations, often in sub-studies. This is going to be a sort of second wave goal for the disclosure core, so something we're paying a lot of attention to. I'm now going to walk through in a little greater detail some of the data on to whom we disclose and details of the disclosure process. So as you can see here, the majority of sites are disclosing, again, to people who have cognitive symptoms or a cognitive diagnosis, though we are seeing an increase in the disclosure of information to individuals who are asymptomatic. And I think this mirrors those who are engaging in PET imaging in trials. We're really thinking more about the earlier stages of the phenotypic spectrum. We also asked sites, who are you sharing these data with? And we see that sites certainly share the information with participants, but also with their loved ones, many of whom attend the disclosure visits. The sites are sharing information with medical providers about 50% of the time, but many commented that there was a very specific process for doing that. Normally either through sharing the results with the participant and having the participant then pass them on to their providers, or through a very specific release of information. As you'll see on the next slide, few sites are uploading information directly to the electronic health record, in part possibly due to concerns of medico-legal discrimination. In terms of the session format, most sites are meeting with participants in person or over some kind of HIPAA-compliant platform like Zoom. Very few sites are utilizing email, and again, very few are sharing to the electronic health record, at least directly as part of the study. We were quite surprised to see that disclosure is a fairly efficient process. Most sites said that these sessions are taking somewhere between 0 and 30 minutes of time. And when we asked who is doing disclosures at your sites, we saw that yes, physicians, but also a really interdisciplinary team that sometimes also included clinical psychologists and neuropsychologists, social workers, other advanced practice providers, and even advanced trainees under supervision. I think this is really important when we think about implementation. We know that physician time can be very limited, and sometimes there are strengths, as I'll talk about a bit tomorrow. There are strengths in including that interdisciplinary team who might have good experience in identifying community resources post-disclosure. We also asked about elements of disclosure visits. Many of the ones that you see here that were endorsed by all of you in your centers map well onto the NAC best practice guidelines that were published by Josh Grill and colleagues last year. So many sites are utilizing some level of pre-disclosure education. This education is really to talk to participants about what information they may or may not learn as part of a disclosure visit, but also the risks and benefits of having that information. We feel that that is a really critical element. How you do that, there's wide variety, and that's something that Disclosure Core will really be working on in terms of developing resources. Other important elements of the disclosure visits include recommendations and action steps. So having some kind of follow-up pathway for participants who have just received their results, regardless of what that result looks like. And additionally, a pathway for clinical referral. Now, we know that many sites are not embedded in a clinic, so the pathway for a clinical referral may be more complex for some than others. One of the things that we find to be very important at Michigan, and I know Wisconsin too, is identifying community-based pathways or resources that might serve for mental health support or other kinds of things post-disclosure. In terms of the format, we see that the majority of sites are still disclosing some kind of dichotomized or labeled data. So we use terms like your amyloid PET is elevated versus not elevated. We try to shy away from positive versus negative because of the natural valence associated with that. In contrast, very few sites are providing quantitative data or a specific risk score. Some sites are working towards integrating participants' actual images. So one of the things that I believe Gil will be talking about in a little bit here is the visual read and also the potential to integrate the participant's actual scan image in reference to negative and positive images. We also asked all of you about why you feel disclosure is important. So of the 19 sites who are currently disclosing information, we were really pleased to see something that I think the Inclusion Corps has touched on quite a bit, and that's the idea that many participants feel that this information is a critical piece of their clinical picture, but also really their data to receive back. So one point of discussion is whether or not we should even use the term disclosure, because in some ways that communicates that these are the data that we're selectively choosing to return to you, but in reality, these are data that we're communicating back to you and you own them as the participant. But again, we see that disclosure could be seen as part of, just responding to participant needs, also a means of increasing retention in our longitudinal cohorts. In the case of amyloid, we are seeing that, with the advent of anti-amyloid therapies, that amyloid PET results have a really clear clinical impact. And so that may be in part why sites are moving more towards disclosure of this information. We asked the sites who are currently not disclosing these different types of data what barriers exist. And we saw quite a few. They are varied across sites, but some of the most common ones are highlighted here. So we recognize that some sites have a lack of expertise in disclosure. They have not done this before. This is really where your disclosure core will come in to provide things like training resources, scripts, educational brochures, et cetera. And these are things Lindsay will talk about more in a minute. Additionally, many of you mentioned that disclosure was not part of the original study, whether that's your longitudinal cohort or an ancillary study. Many of you are using tracers or compounds that are exploratory, so there's concerns about how we come about rating those. And finally, there are concerns about potential unintended harms to the participant. In the clinical core session tomorrow, we're going to be talking a little bit about psychosocial and other impacts of disclosure, so I might put a pin in that point there. But again, this is something that we'll talk about through the disclosure core. Additional disclosure barriers, many of which were specific to tau, included again the use of exploratory compounds, a lack of local radiologic read. In some cases, tau was gathered as part of a very specific study in subpopulation, and so there were questions about whether the validated cutoffs would really apply. And finally, there were concerns about the follow-up piece. So are we prepared as centers to create those pathways and supports for individuals post-disclosure, or is that in some ways blurring the line between research and clinic? Again, this is where I think we can be helpful in providing some templates and pathways for these, and also working with your inclusion and your ORCORs to think more about how you can utilize community-based resources. Some quick limitations to mention. So we did have a not applicable item that was included in the survey when we were first asking you about the kinds of information that you return to your participants. We recognize that we could have defined that a little bit better because in some cases we think that, that sites were indicating that they didn't collect that type of information. In other cases, there were other reasons for endorsing that. And finally, we did know that some sites were disclosing as part of their actual longitudinal cohort, but many were engaging in disclosure as part of another ancillary study, whether that was LEADS or ADNI or something like that. So one of the things we'll be doing in our follow-up visits with each of you, we'll be talking about what kind of disclosure is occurring and in what settings. I'm not going to spend too much time here because that's kind of the queue up for Lindsay's talk. But one of the things that we're working on right now is to partner with the Inclusion Corps and use the data you provided to us on that site survey to identify some pilot sites who might be interested in growing their disclosure process. These sites will be selected specifically to represent the broad and heterogeneous populations that are surveyed by the ADRCs. So we're very excited to start that project and should be reaching out to each of you in the next couple of weeks. If you have particular interest in being a pilot site, go visit Haley and chat with her at the CLARiTI booth. But again, we're really thankful for your interest and time. I'm going to stop there. Just want to say again, thank you so much for taking the time to fill out another survey. We promise not to pepper you with too many more of those. Thanks.
Hi, everyone. I'm Lindsay Clark from the Wisconsin ADRC, and I'll be talking a little bit more today about our disclosure core goals. So generally, our goals are to develop and adapt a flexible biomarker disclosure toolkit, develop training resources and materials, and investigate disclosure feasibility, safety, and satisfaction. So for sites who are already doing this, so sites that are already returning amyloid PET results to participants, it's completely fine in the CLARiTI study with your CLARiTI participants to continue using those processes and relying on that. For sites who aren't currently returning amyloid PET or other results back to participants, or just want to supplement their current processes, we're planning to develop a biomarker disclosure toolkit, including several resources for you to help you kind of implement this process. This will include some consent form language, educational materials, so patient-facing or participant-facing materials for your sites, participant results summary sheets, a staff training manual, and some additional forms and scripts to help kind of facilitate communication of results or guide your visits. To develop this toolkit, it'll be an iterative process. So Annalise already mentioned the beginning here is that we'll be developing and drafting these materials, and then including some of you to help us pilot test how this works, gather some feedback from you, and incorporate that into updating the materials or adding to our resource packet. We'll also be working with the Inclusion Core to gather some information or feedback on the materials from community partners through their Community Science Partnership Board. And then after that, we'll finalize the toolkit and disseminate it through NAC so that all sites will have access to it. We're hoping to have that done by the end of this year or early or next year. We'll then continue to update the toolkit as we have additional materials available. So once we're ready to be sharing back tau PET results, for example, we'll update the toolkit to include some more specific materials related to that. The toolkit will start really focused more on amyloid PET disclosure. And then as we continue to work with sites, we'll iteratively update materials as we get feedback on how things are going. In general, the biomarker disclosure process that we recommend will be similar to evidence-based practice in disclosure that have been used in clinical trials or other observational cohorts, where we have some pre-disclosure activities focused on assessing readiness for learning results and providing some education on the risks and benefits for learning results, or kind of generally what the biomarker test process disclosure process looks like. In the return of results visit, we'll provide some checklists and things, but generally this will include assessing what a person knows about biomarker test results and confirming that they're ready to learn their results, returning the results using non-technical words, pauses, both verbal and written report of results, ensuring that a person understands the result and assessing kind of that initial reaction, and then having some materials or resources available for the participants to be able to prepare for next steps. After, we'll recommend that sites that are able can follow up with participants a couple of weeks later to kind of check in with participants, see if they have any additional questions, and potentially administer some additional mental health or research questionnaires. So as our core, or as Annalise mentioned, we will be developing some training resources. This will include a training manual, training sessions that we might be able to do at some of these upcoming in-person meetings or webinars that will be available online. Some individual consultation with sites so we can help sites think about how to adapt this process into their individual workflows or work with particular communities. And then we'd like to evaluate the effectiveness of these training resources and materials. We also want to look at some basic research outcomes related to this process. So feasibility, how many participants are interested in learning their results or opt into doing this, how many sites use the toolkit materials or kind of increase their disclosure practices based on the availability of these resources, for example. Safety, looking at things like mental health questionnaires before, after learning results, and comprehension, just how, do people understand what these results are? Do they need more additional information? What kind of educational resources are still needed? And then satisfaction, are participants, satisfied with the process for learning these results, for example. So that's all I have, kind of short and sweet today, but I'm happy to answer any questions after the session or chat more. And you can always email myself or Annalise afterwards if you have additional comments, feedback, or questions for us. Thanks so much for your time.
So since we have such an awesome disclosure core, we need to actually give you something to disclose. And so I just wanted to review how we are planning to clinically interpret amyloid PET scans in CLARiTI. So our approach is actually based on what we have done in the LEAD study. Actually, the LEAD study, I believe, was one of the first observational study to pilot disclosure of amyloid and then tau PET results to cognitively impaired participants. So we have visual raters. I'll show you who they are. They have completed training, FDA-approved training in amyloid PET interpretation. They review the scans blinded to any clinical information and put in a visual read based on the criteria for that tracer. The criteria are similar but not identical, depending on which amyloid tracer you're using. And then they actually receive a specific SUVR or Centiloid result for that scan. And there are thresholds that we are using that are being used in ADNI, so 18 to 20 Centiloids, depending on the tracer that's being used. Now, the clinical interpreter, if their visual read and the quantification agree in classifying the scan as elevated or non-elevated, and they feel confident in that interpretation, they don't want another set of eyes, then they're done. But if there's discordance, that automatically goes to a group consensus. And if the reader just wants another opinion, that also goes to consensus. So we're really trying to provide you with the most accurate interpretation possible. And so what you receive as a site through an electronic case report form, you get a final binary read of elevated, non-elevated. You get information about the regional pattern. So we check off which cortical areas were involved. There's some additional notes if there's something unusual or subtle about the scan. And you also get the SUVR, and we're hoping a Centiloid value added to that scan. We are, as was mentioned, developing methods for tau PET reads. The only tau PET tracer that has an FDA-approved interpretation method is fluorotaucipir. So we are working with the companies that are developing interpretation methods for MK6240 and PI 2620, but also with the new criteria coming out, we want to be able to provide you with tau's PET staging, so you can use that in the new criteria as medial temporal lobe only, moderate neocortical, or high neocortical. We don't know yet exactly how we're going to do that, but we're going to develop methods, and they'll, similar to amyloid PET, they'll integrate visual interpretation with quantitative values. This is just a summary of Centiloid values in visual reads in LEADS and ADNI. So I'm sorry, they're flipped, but here, these are Centiloid values for scans that were interpreted as positive. These are Centiloid values for scans that were interpreted as negative in IDEAS. And in ADNI, it's flipped. So these are the negative scans. These are the positive scans. Overall, we're seeing very high concordance between the SUVR values and the visual reads. So actually, not a lot of scans need to go to consensus. Though again, raters can actually, if the scan is tricky, even if it's concordant, they can ask for a consensus. And then we will provide you with a template for each tracer based on the way that tracer is read. And this is all open to discussion if this is useful, but this is what we do in LEADS. And so, for example, this is for phlorbeta-benzo and gray-white scale, an example of transaxial slices from a prototypical negative scan, a prototypical elevated scan, and then that individual's scan in the same cuts, in the same spatial, so that you can, if you want to review these with your participant, you can say, you know, your scan looks like this one, and here's why, and so forth. So hopefully that's helpful. And then finally, these are the folks who have generously generously volunteered to be part of our initial clinical raters. You can see we have a nice distribution from different ADRCs. We have neurologists, we have nuclear medicine physicians involved. We hope that the consensus will take place with as many people as are available. We're going to try to do that monthly. And then just a shout out to our UCSF folks, Anna and Zoe, who are helping with the coordination and processing of all of this information. So that is all I have for you. And I think we're ready for the discussion part.
Yes, we will welcome back up. Yes. We'll welcome back up the disclosure core speakers. And we do have a question from Penny Dax online. The first question is, will biomarker disclosure include discussion of potential external ramifications like insurance?
Did they say what was last?
Yeah, I can repeat that. So will biomarker disclosure include discussion of potential external ramifications like insurance?
Yes, we will include in our educational brochure and materials some information about potential risks or external ramifications like insurance and, you know, considerations of purchasing long-term care insurance prior to learning results for those who are cognitively unimpaired, for example. So absolutely, we'll be including that information with the disclosure toolkit. Thanks for that question. Please.
Yeah, hi, Andrew Budson, Boston University. Wonderful presentations. In terms of getting the information back on the PET scans that are sort of borderline, you know, our site would probably prefer to sort of hear back that this is a borderline site so that we can use, you know, other biomarkers, you know, CSF, plasma, before we speak to a participant. Will we be informed that it's in that borderline range?
Yeah, that's a helpful helpful feedback, Andrew. So you will know whether it went to consensus or not. So any scan that went to consensus, it's going to be one of two things. Either it was equivocal or there was discordance. So you can assume all those scans are borderline scans. In the notes, we can enter you know, why we ended up interpreting the scan. So we can say, you know, there was perhaps subtle blurring of the gray-white junction in the left frontal lobe, but upon consensus, the raters determined that that was an atrophy artifact. And so the scan is determined to be non-elevated. We'll try to put those kind of comments in. And you're always obviously welcome to reach out to us. And if there are questions about specific scans, also, y'all will be looking at them and you can, you know, you're always welcome to reach out. And that happens in leads occasionally. People receive the results and they ask us for a little more information. And we're always happy to do that.
Thank you.
Hi, thanks, Jim Brewer, UCSD. Awesome to see all this moving forward. I'm absolutely an advocate for disclosure, and I think it's great for our patients and participants that want to be enrolled in the studies. I think we've got the ethics ducks in a row. I think the only thing, and I brought it up before, the only thing that we don't have expertise in is the legal aspects of it. And I just encourage at least hearing from a lawyer who will give you their scariest input about what could go wrong. And then you decide, well, what's the risk benefit and what are the ways to mitigate that risk? Because in leads, it's been going great. It is under a study. So you kind of you have a safety umbrella there. In some of this, there are going to be people that are going to say, I want to use this same scan for my clinical care and decision of getting a drug. And there you're getting into some waters that I'm sure a lawyer is going to say, wait a second, who read this? Are they certified in your state? All those kind of really crazy things that they will bring up And then you just want to make sure that you've thought about it and mitigated the risk.
I'll just note, I think that's a really excellent comment. There have been a few wonderful publications in the past few years, including from people like Emily Largent, who have an experience in both kind of law, public health, the psychosocial aspects. You know, it's a quagmire. There's still a lot to wade through. I think where we're also going to have to be really careful is this translation of the research data that we disclose to a clinical setting. And additionally, thinking about all the ancillary studies that we support. So we disclose, for instance, the Michigan ADRC, but we have really strict stipulations over how we share data with other providers. We counsel participants very carefully about the potential implications of that. But we also have a lot of studies that then recruit through our center based on the biomarker result. So that then behooves us to educate the other studies about the potential implications of sharing those data or explaining why a participant might have been recruited based on a biomarker status. There's a lot left for us to learn, but we are very carefully thinking through each of those pieces and getting counsel from lots of folks with experience in that area.
Yeah, I think it's really, you bring up some really important points, Jim. And I think it is always, and hopefully, I'm sure this will be in the materials, these are research results. And so they should be disclosed as research results. And if people want to go ahead and, use them for clinical decision-making, buyer beware, and, it may make sense to have the scan overread by your local licensed person or, whatever process makes sense to you. That's the key thing. We have to be clear with all our participants. These are research results. They're being disclosed as research. They're not being done, in a way that's FDA approved, et cetera, et cetera.
I think we have a question.
Great. We have another question online from Jen Lingler at Pitt. She says, thanks so much for the overview. And do you have a sense of the time frame for getting the scan results back to the sites?
What did we say, Beth, there in Sterling? I can't remember. In ADNI, it's 90 days, I believe. I'm not sure what we committed to in CLARiTI. Actually, I don't remember.
Actually, I don't think we committed to a time.
In ADNI, we're doing it as 90 days. We hope that we'll be able to do it much sooner than that, but there has to be some alignment. These images have to go through QC by Bob Kepi. Like there are a few steps that need to happen. So, this isn't, again, it's not clinical work. So in the clinic, you do an amyloid PET scan. Hopefully it's interpreted that day or the next. It's not going to be on that timeline. And, if occasionally, I'll just preempt this, occasionally in leads, for example, it comes up that sites have some time limit and they're like, the participants coming in, we really want to know. You can send those requests. We'll do our best, but, there's a huge number of scans in CLARiTI and, we can't guarantee, and maybe the scan needs to go to consensus and that's only happening once a month. So please set expectations with your participants around a 90-day turnaround time. And if there are some extraordinary circumstances, we can do our best to accommodate those, but we can't promise.
Josh.
Josh Girl from UC Irvine. Thank you, everybody. Fantastic work. A quick confirmation on the survey. Did you indicate that 84% of responding ADRCs are now giving amyloid PET results to cognitively unimpaired participants? Or was that a percentage of a percentage?
That was a percentage of a percentage. Yes,
Very good,
but it's
thank
not
you.
84%. Yeah.
I think
And-
it was
Of the
53% total are disclosing amyloid PET results, and of those 53%, 84% are disclosing with cognitively unimpaired participants.
Thank you. And a second question. On the tau PET and the regional information, does that introduce a possibility that someone's research tau PET result would be different from the FDA approved outcome of that? And what are your thoughts right now about guiding the centers in delivering that type of information back to participants in impaired versus unimpaired, et cetera?
Yeah, it's a good question. So we haven't made any of those decisions. There's only one FDA approved training method, and that's for fluortaucipir. There will be more FDA-approved training methods we expect for MK and PI. People are working on those methodologies. So, we're open to input, I think. We have two sets of criteria. We have the FDA criteria. We don't know what that will look like for MK, for example. Maybe it will include medial temporal lobe only. Maybe it won't. I don't know. And then we have the FDA criteria. And so, we want to provide the centers with something as useful as possible. It could be that we just say this scan shows MTL binding, which does not meet the FDA criteria for a positive Talvid scan. But that way you have the staging of MTL only, and it's not, meeting that threshold for the FDA. But, we'll have to figure that out. If you have ideas, we'd love to hear them. Great.
Maybe I'll ask a question before we wrap up. So, CLARiTI is just one source of imaging, of harmonized imaging that's going to be coming through the ADRC program. In fact, all the centers are collecting as part of the new RFA non-CLARiTI scans for amyloid and tau PET. Have there been discussions with the scan team on implementing similar procedures kind of across the board?
Yeah, I've reached out to the scan team, my good friend Bill. Yes, we've started discussions about it. Our team would be happy to use the identical methodology. We've proposed to do that. I don't know where things stand, and I don't think it would happen until there's a competitive renewal that's approved, Bill. But Bill can update us on where things stand.
Yeah, so Gil's 100% right. And I really, I guess what I'm about to say could be taken in the wrong way, but I think we have to ask the question of how scalable this approach is that we're currently using. I mean, UCSF has pioneered this, to perfection. I mean, we're extremely happy to be working with Gil and his group, and we, I think, have a workflow that is working well. And I mean, with in relationship to the time lag in ADNI, we seem to have it down to 30 days, and I think we can do better than that. So I think it's great, but there's a lot of need out there. And the question is UCSF going to be able to meet all of the need for visual reads on all the scans through the ADRC system? And maybe it will, actually, in which case, I'm all for it, but I think it's a question that we really have to.
Yeah, so I'll say no, actually.
I kind of thought you might.
But we're happy to coordinate. So what we're doing, so for ADNI, actually, the volume was such that we could all handle it within UCSF. For CLARiTI, we've included representatives from other ADRCs. And I think what we could do is we could scale the number of readers so that the burden on any individual reader isn't higher, and yet we can double or triple the capacity. And so I do think that this system that we've put in place could handle all the ADRC scans, but it involves now, raters outside of UCSF, which is great. And I actually think we're going to learn a lot in these consensus meetings. Maybe we can even open them occasionally as teaching, like radiology rounds, where as teaching opportunity, because I think we'll learn about how different centers and different clinicians approach these reads. And I think the whole system will be better off for that large scale collaboration.
Yeah, I think the other thing it would do is install some of this expertise at multiple ADRCs.
Yeah.
Okay, we're gonna end there. Just a few quick closing remarks. So I really want to thank all our speakers. It was an excellent set of talks. I want to thank the ORCOR leadership for their support and partnership for the start of this project. I want to thank some folks from Wisconsin and NAC, in particular, Lori, Aaron, Phoebe, Heather, and Brittany for organizing today. And yeah, I think this is a really exciting time for the project. We've already learned a lot about site level operations, and I think we're going to continue to learn as the study actually begins over the next few months. So thank you all for your attendance and your attention, and let's again thank all the speakers.